Hey guys, and I guess welcome back to class. Sorry about the projector thing today, but I'm glad that we have the option to move this class lecture online here. And in reality, this might be a really nice thing for you to utilize studying. So at this point, you should have watched the ankle anatomy video that's like a 6-minute video online, and then watch this screencast. And then from there, then I'll do a separate one on the foot. So you have 2 videos to watch on the anatomy tutorials and then 2 screencasts, and I'll break it up by the ankle and foot. And hopefully that'll go well. So with the ankle video, that 6-minute one, I thought they did a nice job of covering the different movements and talked about the different ligaments as well as the musculature of the ankle joint. Now, I'm going to be going off of the PowerPoint presentation that's also on Blackboard here, and then I've also pulled up a couple other random videos and things that we can take a look at. So the first thing that I want to show is the bony structure. We kind of always start with the bone and then we'll work out. So the bony structure of the tibia, and the video did a nice job of going over the articulation of the tibia down here with the talus, which makes up the talocrural joint, these 3, the fibula, talus, and tibia, and how the tibia is their weight-bearing bone. So remember that the tibia bears all the weight, whereas the fibula provides some structure and support, kind of widens our base down there at the base of the ankle. Remember that the top of the fibula, right here where my cursor is pointing, is called the head of the fibula, whereas the distal-most aspect of the tibia, which is on the lateral or outside of the ankle, right here, is the lateral malleolus. The medial malleolus is slightly elevated from the lateral one right here, and it is the distal and most medial aspect of the tibia. Remember, then orient ourselves here. This bump just distal to the patella is the tibial tuberosity, where the patellar ligament attaches there, which you don't see in this picture. As we go there, the one thing I did want to point out, let me go down to slide 4 on your PowerPoint. In the video that you just watched, it talked about the tibiofibular joints and how you have the ligamentous, the small ligamentous joints out down here, and then you have this membrane that you can see it going all the way up, and this is called the syndesmosis or interosseous membrane, and it does travel all the way from that distal part of the ankle joint all the way up almost to the knee. And the video explained this, but it really didn't kind of zoom out and give you the picture of the whole lower leg. So I wanted to point out that this membrane does go all the way up. Now, this is a very important membrane, and it is a syndesmotic type of joint. And when we're trying to classify that joint, it is a fibrous joint. So fibrous type of joint, syndesmotic. I bet for a test that might be coming up in about a week, you will have to know that the syndesmosis, the tibiofibular syndesmosis, where that membrane that goes between the fibula and the tibia here is classified as a fibrous joint, meaning it does not move. Okay, it's not supposed to have movement. If you remember, other fibrous joint examples were like the different bones in our skull. We don't want movement to occur with those. Very common for this joint to, this fibrous membrane to become disrupted when somebody has an ankle injury. High ankle sprains mean that the ligaments of the distal fibula are disrupted, and when they're disrupted enough that the fibula can actually pull away from the tibia, it starts ripping that membrane and disrupting that connection so that the fibula is actually moving, and it can go fairly high. So if there's a disruption, that has to actually be repaired a lot of times through surgery. Now, I have a buddy of mine Dave Saper is an orthopedic surgeon. I'm on his Instagram page here that you can see. He's an orthopedic surgeon in Chicago, a good friend of mine. And he started this Instagram account that he posts pictures from the OR and things like that. And if you look here, he's got this one of a broken ankle. And what you can see here is it actually has 2 fractures, and those are in red. This part here, and that's on the fibula. So we're looking at an x-ray here. The bones show up as like a lighter white, and then soft tissue is a little bit darker gray here, almost to black. So the fracture's right through here, and that's a fracture of the lateral malleolus, so the bottom of the fibula. And then this here is the tibia. And so we're coming down, and see that little triangle shape here? That's actually that distalmost aspect of the medial malleolus. So what we call this is a bimalleolar, both side malleolar ankle fracture. Not a good thing. If you see this little blue line that Dave drew in, or Dr. Saper drew in, this is outlining the mortise. So this is where the mortise joint is classified as the talocrural joint. It's the space between that. And it should be lined up where the base of the tibia here, and it's bordered by the medial malleolus, should fit perfectly with the talus. And the talus has slid over to the lateral side here. What we don't see with this, because it's just an x-ray, we don't see the bones on it, we're not seeing the ligamentous disruption. So everything's kind of slid over to the lateral or outside, and that's actually caused the syndesmosis here that goes all the way up between here, remember, fibrous joint, to shift to the side, and it's broken some of that syndesmosis. So what Dave had to do with this is he had to go in and put a plate with, you see all these bunch of screws over that lateral malleolus to line up that fracture, put a big old screw there on the medial side to line that back up, and this long screw right here is actually holding the syndesmosis back in place, so that fibula doesn't jut out to that lateral or outside when that person steps down, and it's holding that together until that syndesmosis can repair itself. So that's what those are. You can see here the nice difference in the mortise joint, where you have this nice even space all through the talocrural joint, the bottom of the tibia articulating with the top of the talus. So really nice repair by Dr. Saper there. I wanted to take a look here also. This is a nice picture of just all the movement that occurs. We're going to get into the foot in a bit. But when we flex and extend, remember dorsiflexion, bringing the foot up, and then plantar flexion, pushing the foot down like you're pushing on the gas pedal, or that walking motion. Just look how much motion is occurring in every single one of those bones within the foot. It's just incredible when you think about it. This is an open chain thing, so the person's not actually stepping down on anything. So this is just like we're foot's in the air. Versus when we step down on something, we have different types of motion, but still you can just see how much movement is occurring. This is one of the challenges of looking at the foot and ankle, is that we really have to look at each joint separately. So for example, here we're looking at the talocrural joint. Here's kind of hard to see, but there's the fibula here on the outside, the tibia on the inside, and there's that medial malleolus on the inside. And then here's the talus right there under the articulating with the tibia. And that's that talocrural joint. It's responsible for dorsiflexion and plantar flexion. This is going to be a test question, guarantee. Talocrural joint is responsible for dorsiflexion and plantar flexion. But we already identified in class today that we have another set of movements that occur at the ankle, and that is inversion and eversion. Inversion, eversion. Rolling the foot in, rolling the foot out is kind of what I think of when if inversion, eversion. Inversion, eversion actually occurs just below that talocrural joint at something we call the subtalar subtalar joint. So sub, think below, and talar is the talus, so that bone. So below the subtalar joint, below the talus is the subtalar joint, and that's the articulation of the talus and calcaneus. So there's the talus right there, sitting on the calcaneus, which is our heel bone. Notice with the calcaneus, we've got this big area of the back of the calcaneus. So this is the whole bone here. Big area in the back that does not articulate with the talus. Instead, you have the significant Achilles tendon coming and attaching right there on the back. So all this back here is filled with soft tissue, specifically the soleus and gastrocnemius, or the two muscles coming down then into that Achilles tendon. The Achilles tendon, though, very superficial, very easy to feel or see even if you have your shoes off to see on the back there. But pretty wide gap between the base of that and then coming into where the bones are actually articulating. So right here, subtalar joint, calcaneus and talus, so where those two are connecting. And that is the joint responsible for inversion and eversion. So we've got talocrural joint here, responsible for dorsiflexion, plantar flexion, bringing the foot up, pushing down on the gas pedal, bringing the toes down. Here, inversion, eversion. Very important concept. For sure is going to be a test question. Make sure that you understand how that works really well. We also have this different motion in the foot. If you hear people say, pronation or supination, what that means is a little bit different than inversion, eversion, because it's kind of a combining of movements. And usually this is not something that the person's intentionally doing. This is standing in a neutral foot position. And if our foot either kind of caves in to the medial side, so this is the inside, it's called pronation, where the medial side of the foot kind of collapses in. Sometimes people refer to this as they're flat-footed. If they were to get out of a pool and then walk on the pool deck, it would make big marks on that mid-foot area where you actually might see the whole foot. Versus the supinated foot, somebody could say they have really high arches, and that's a supinated foot, where that foot kind of rolls onto that lateral aspect, and the middle of the foot doesn't even touch the ground. So somebody that walks on a pool deck here, you might just see the heel, the toes, and then maybe a touch on the outside, whereas it's just going to be this big gap in the middle. Versus this pronator, you're going to see the whole footprint on that pool deck. So that's kind of the difference with them. And there's all kinds of information out there on pronation, supination, and what that does to your foot, what it does to your gait or how you walk. And there's different treatments based on the severity of a pronator or supinator. Orthotic use is a big thing. So there's whole sections on foot biomechanics that this applies to. But I wanted just to point out that pronation and supination is different than that inversion, eversion. So it's important to recognize those differences. So we've kind of taken a look at how that works. We're going to jump back up now into some ligamentous things. Again, as we're looking, that interosseous membrane, right down, and it goes through the whole thing, fibrous joint, okay? And that's the syndesmosis here. The anterior tibiofibular ligament, so connects the bottom of the tibia to the base of the fibula right there. Important one to remember. That's certainly when we looked at Dr. Saper's ankle, the bimalleolar fracture, the anterior tibiofibular ligament was disrupted, and that's one of the other things, that long screw that he put in that connects or that holds the interosseous membrane was also holding the anterior tibiofibular ligament. So important one for high ankle sprains, or ankle fractures. Not to be confused here with the anterior talofibular. So again, another one that connects on the fibula, but this one goes to the talus. So this is part of the ankle joint we'll talk about in just a minute. Another important one connecting the fibula to the tibia is the anterior ligament of the head of the fibula. And that's right here at the top, connecting to the lateral tibial plateau up here, and then the head of the fibula here. So important to orient yourself with those. I'm going to skip ahead. If you're looking at your PowerPoint, I'm going to skip just a touch because I'm going to circle back to the ankle in the next one. We look at the talus here. I'm on slide 11 now if you're following along in your PowerPoint. We look at this one here. This talks about the talus specifically. And remember the trochlea here is one of the articulation places with the tibia, sorry guys. And that's going to have that articular cartilage, that nice smooth cartilage. In last class I talked about it like the chocolate coating on a pretzel, and I love that analogy for whatever reason, so I'll say it again. But that coating, about I'd say 1/4 of an inch thick or so in this area, enough that it provides enough cushion to protect that area, but not so much cushion that it's going to not allow those bones to glide, to disrupt any kind of musculature attachments in that area. So again, that's the talus. Now, jumping down to some ligaments here. The talocrural joint, aka ankle joint. Talus and the tibia and fibula all coming together as a synovial hinge diarthrotic joint, responsible for dorsiflexion, plantar flexion. So important that you guys know that. Also, you've got 5 different ligaments all around here, and I would be willing to bet you would see this picture again and have to label those ligaments. So let that be a hint for you guys. Remember, we've got this one here. The syndesmosis would be up here. You can't really see it. But this is connecting the talus, the tibia and fibula. So anterior tibial fibular ligament right there. And this is our posterior tibia fibular ligament. So those two really hold the fibula on to the talus. Then we have these 3 other ligaments. Right here is the anterior talo, so talus right here, fibular ligament, the calcaneofibular, calcaneus and fibula, and the posterior talofibular ligament, so back there. These 3 ligaments are the ones that if somebody has a lateral or outside ankle sprain, these are the ones that are injured. It's that rolling in mechanism. Most common ligaments to injure with an ankle sprain are the anterior talofibular and the calcaneofibular. So these 2 are the most common that if you've ever had your ankle sprained, that's probably the ligaments that were involved. So we move to the inside of the ankle now. So again, that was the lateral aspect, we know, because of the fibula. Now we're on the inside, or the medial aspect. We've got this mass of ligaments. There's 4 different ones. And these are so closely related, and they really overlap each other, that we describe this as the deltoid ligament. But really the deltoid ligament is 4 ligaments that all just like run side by side. You do not need to know all 4 ligaments. Just know that the medial aspect equals deltoid ligament is the big one. And that is just connecting the things in the talocrural joint on the medial aspect. So prevents excessive eversion. Really rare to have an injury to the deltoid ligament, because if somebody tries to evert or turn their foot out, we have a bony restriction being the fibula that's coming down. Sorry guys. The fibula comes down and actually prevents us from being able, and you can see it on this one, prevents us from everting. So if the deltoid ligaments were right here where my cursor is on the medial aspect, they're not going to be stretched that much because unless somebody breaks off their lateral malleolus, which does happen obviously, that bony block is going to prevent us from putting too much strain here. Versus somebody that rolls their ankle in, there's no bony structure that's blocking that ankle from turning in. That's why it's so much more common to have an inversion, rolling the foot in, ankle sprain, and to disrupt those anterior talofibular ligament and calcaneofibular ligament here. Sometimes the posterior talofibular, but like as I said, that's not as common to be disrupted with an ankle sprain, but those are the ones being stretched when somebody's turning their foot in or inverting it. So we look at the subtalar joint. So again, sub below the talus, it's the calcaneus and talus. Gosh, I can't even talk right now, sorry. It's a plain synovial joint. And again, movements, inversion, eversion. So important for you to realize that and remember that. Contributes to pronation, supination, but as we showed just a bit ago, this is not, pronation, supination is very different than inversion, eversion. They're similar movements, but they're different. And then we've got the talotarsal ligaments that are supporting this joint. Okay, so the slide 23 of your PowerPoint does show another picture of the supination, pronation, talks about the different movements that are being combined for these biomechanical problems. So take a look at that. I want to jump down into muscular anatomy. I'd like to start off saying that the lower leg is divided into compartments. There are 3 compartments, and it's the lateral, the anterior, and then the posterior. The posterior compartment is divided into a deep and superficial, but 3 main compartments when we're talking about the lower leg. This, each compartment contains muscles, blood vessels, and nerves, all the different things that allow our distal segment, the foot, the toes, to move and to be supplied by nerves, so we get feeling down there as well as get blood supply down there. Let's first look at the lateral compartment. Muscles in the lateral compartment are going to be responsible for plantar flexion and eversion. That's the PF and EV. So pushing down on the gas pedal or turning the foot out. And these are primarily the peroneus longus and brevis. The brevis is the one that comes down and attaches. This is the metatarsal of the foot. We'll talk about in the next video a little bit more extensively. But that's that brevis attaching right there on the base of the 5th pinky toe metatarsal. So right up there. The longus, it's hard to see, but it loops. You can see it right here. It loops under the foot, but both tendons come up, hook right around the back of the lateral malleolus. So that's the base of the fibula coming down. That's that lateral malleolus. They hook side by side right around there, and then they travel up and attach up there by the fibular head there. The peroneus longus and brevis work to evert the foot, turn the foot out, but they also assist a little bit with plantar flexion of the ankle, and that has to do with that talocurl joint. The nerves that the peroneus longus and brevis, the nerves that are involved are both the superficial perineal nerve. Superficial perineal nerve. This is an easier one to remember because perineal muscle, perineal nerve. Great. The superficial perineal nerve originates from L5 primarily, so lumbar root number 5 comes down, and then the branch that innervates those muscles is the superficial perineal. These are important muscles that you'd use, like if you're hiking on like a really rocky trail and your foot has to kind of stabilize itself. These ones would be firing up. If you go ice skating this winter or skiing, the E version that occurs at the very end of a stroke ice skating or skiing would use the perineal muscles. So that's gives you an idea of the muscles that we are talking about. The next compartment, anterior compartment, forgot about that one. So anterior compartment is responsible for, DF is dorsiflexion, eversion, inversion, and extending the toes. And that's page 379 of your book. There are 4 muscles that make up the anterior or the front compartment. That's that tibialis anterior. That is a muscle that's responsible for dorsiflexion. And that's one that if you've ever heard somebody talk about having shin splints, it's usually the tibialis anterior that is responsible for that. But it has some role in inverting the foot and then also dorsiflexing the ankle. That's innervated by the deep perineal nerve, different than the superficial perineal that was on the perineal muscles. Also, deep perineal also comes off of nerve root 5 in the back and then branches down. It just has 2 different branches in this area. So tibialis anterior and then extensor hallucis longus, that's what EHL stands for, and extensor digitorum longus. These are the fairly prominent and easy to see tendons on the top of our foot go into these 2 muscles. We'll talk about those a little bit more in the video. Peroneus tertius is the 4th one that has to do with the anterior compartment, also some really similar involvements. You can see a nice picture, we'll talk about it in just a minute, but see these like, kind of like, they look like spider webby kind of material there. These are retinaculums. So we have the superior and inferior retinaculum here, and you've got some more on the sides that we'll talk about. But the retinaculum, you can see how they're doing a nice job. Think of it just kind of like a bandage or like a rubber band kind of holding things in, or a strap that goes over the muscles and tendons, because those, this area of the foot, it kind of takes almost a 90-degree turn depending on what angle the foot's in. And if we didn't have the retinaculum, the tendons, based on what muscles we were using, would just kind of pop out from hugging the rest of the anatomy underneath. So it just kind of holds it to the body, which serves a really important function, actually. The last compartment is broken up. So we've got the posterior compartment. We had the lateral, anterior, and now the posterior compartment. And we'll talk about the deep posterior first. This has got the flexor digitorum longus, flexor hallucis longus. So the anterior had the extensor ones. Now we're talking about flexing the toes. And the tibialis posterior. These 3 are often called Tom, Dick, and Harry. Tom is the tibialis posterior, Dick is the flexor digitorum longus, and then Harry is flexor hallucis longus. And these 3 tendons all hook right behind the medial malleolus. So we had the perineals on the lateral. Now we've got these on the medial malleolus. And they're responsible for flexing the toes and inverting the foot. And they're just a group there. If we go then now to our last compartment is the superficial posterior, that's where we really are more familiar, I think, because that's the gastroc and soleus, as well as a muscle called the plantaris, which we sometimes forget about the plantaris because the gastrac or gastrocnemius is such a prominent muscle and one we think about. Important things here. These are all responsible for ankle plantar flexion. The gastroc has 2 heads, and you can see them really defined there. And then they come down into the Achilles tendon and attach down onto that calcaneus via the calcaneal tendon. These the main difference that I want you to always remember between the gastrocnemius and the soleus is the gastrac has the two heads, and this is a multi-joint muscle. It's responsible for plantar flexion of the ankle, or if we raise up on our toes, this is the main muscle that's working. But it also, see the attachment there, it attaches on the fibula, so it crosses attaches on the femur. So it crosses two joints. Very important to remember this. So it is involved in flexion of the knee. Versus the soleus. Soleus is one that is underneath the gastroc, so you don't see it well in this picture. And it is much thinner than the gastrac, but the soleus attaches on the top of the tibia there, so it does not cross the knee joint. So that's the major difference between the two. It's a nice picture of the gastrac there. So important to remember. The tibial nerve is the one that innervates these, and those come off of even lower onto the spine roots. Really, we're looking S1 or S2, and then it comes down and branches off and becomes the tibial nerve, and that's what's innervating both of these two muscles. The last thing I want to show you are the retinaculums here. So we have, this is again the lateral or outside of the foot. We see the lateral malleolus here. And we have two retinaculums. Remember, just bands of tissue that are holding things in place. The superior and inferior perineal retinaculum. We see that here's that peroneus longus kind of looping under the foot, peroneus brevis attaching at the base of the fifth metatarsal, hooking behind the lateral malleolus. So we've got two that are kind of holding that in. And then we have two up here, the superior extensor retinaculum and the inferior extensor retinaculum. Those are ones that go over those extensor tendons of the toes, and that's what we saw back on that other picture. So important to realize these are really important structures that serve that purpose of holding the tendons down. There's a medial aspect. So we also, again, we're looking at the superior extensor, inferior extensor that we saw on the other view. And then it's a nice picture of the flexor retinaculum. There's Tom, Dick, and Harry all hanging out underneath there, those tendons that work to invert the foot and also have some role in plantar flexion. The deltoid ligament would be under this flexor retinaculum, but it's not pictured in this image. So remember the deltoid ligament, or the group of four ligaments on the medial aspect, but we call it just one deltoid ligament. All right, guys, so that is a recap of the ankle joint. And now in this next video, I'll move down into the foot. All right.